All right, everyone, thank you for joining today. We're going to be discussing improving outcomes during transitions of care. Please add your questions to the Q&A at the bottom of your screen or enter them into the chat. With you today, we have myself, Joey Pellerito, Director of Pharmacy Operations for Genoa Healthcare in Southern Arizona. I oversee the pharmacies within Southern Arizona with the goal of achieving better health outcomes for those with behavioral health and other complex health conditions. Before that, I was a pharmacy manager within CODAC, and previously joining Genoa, I was a pharmacy manager at Albertsons Companies. Next, we do have Katie Lozano, Director of Pharmacy Operations for Genoa in Oregon and Idaho. She was a site manager with Genoa at CODAC in 2017 and 2019 before moving to Portland, Oregon in August of 2019 to be the Director of Pharmacy Operations. She lives in a suburb of Portland with her husband and son, who turns 1 on Saturday, and they're expecting their second son in February. Fun fact about Katie and I, we went to pharmacy school together at the U of A in Tucson. I took over for the pharmacy at CODAC after Katie moved to Oregon, and now we get to be directors together. So we've come full circle presenting with you today with CODAC, as this is the partner that we serve patients and clinic staff as our time as pharmacists with Genoa. Then lastly, we do have our guest speaker today, Nancy Bibi Sabatz. She's our Senior Director of Utilization Management at CODAC Health, Recovery, and Wellness. Nancy has been with CODAC for about 11 years. She is passionate about client-centered care, and particularly in serving those who face the most significant socioeconomic challenges. Nancy has worked with both children and adults in various systems of care. She is a licensed health professional with a bachelor's degree in health and human services and a master's in counseling. Nancy is originally from Michigan and has been enjoying her time in Arizona for the last 25 years. All right, and we'll have Katie present our current landscape.
Yes, thank you, Joey. My apologies for my voice. Like Joey said, I have a almost 1-year-old, so I am the lucky recipient of many a daycare illness. So I sound like I have a frog in my throat just a little bit. But our current landscape for transitions of care, the Centers for Medicare and Medicaid Services defines a transition of care as the movement of a patient from one setting of care to another. So settings of care may include hospital, outpatient, ambulatory specialty care clinics, long-term care facilities, home health, and rehabilitation facilities. And we have also included the transition from a correctional facility or mandated/court-ordered therapy to outpatient care in our definition, as this is a common transition that we also see in our practice setting. And this is important to us because these transitions between care increase the risk of adverse events for our patients due to the potential for miscommunication as responsibility is transferring from one care team to another. And as we all know, hospital discharge is a very complex process. There's lots of new instructions, meds may be changing, possibly the change of providers, changes in the level of care that a patient may be receiving, changes in living arrangements. So it's no mystery that this would be a time of significant vulnerability for our patients. And safe and effective transfer of responsibility for our patients' medical care, it heavily relies on effective communication between the care teams. As our patients are transitioning from one to another, that we're communicating and we're talking about the changes in meds, the changes in therapy. It can be a confusing time and there's a lot of information and a lot of things are changing. So communication is key. Right, thank you, Joey. So some statistics to set the stage for us. 40 to 50% is the estimated readmission rate for psychiatric patients within 1 year of hospital discharge. So about half of patients that come out of the hospital will likely return within 1 year. And less than 50% of discharged patients are connected with outpatient care within 7 days. which is a widely accepted quality of care metric in the United States. And last, 80% of serious medical errors involve miscommunication between caregivers during that time of vulnerability as they're being discharged from hospital or changing care hands during those transitions of care. All right, I'm ready for the next one. So our first poll question to the group is, does your center have any partner programs in place to support patients who are transferring from one setting to another? If so, please select the patient scenario on the screen. And please feel free, if one of those first three options does not apply to your clinic, please feel free to enter in another scenario in the chat.
Alrighty, our first discussion question for today. Nancy, what challenges have you experienced when patients have transferred from one healthcare setting to another? How have you addressed those challenges?
Oops. Hi, thanks, Joey. Yeah, so to begin with, one issue that we struggle with is complete discharge packets when our members are leaving level 1 and crisis hospital settings. And oftentimes we'll get a packet that doesn't include everything like the long-acting injectable medication and the complete discharge summary, meaning the MAR, the meds that they receive when they're in the hospital, will be there, and then the complete discharge summary may not be. And you know, our members often, when they come out of a crisis facility, are experiencing a variety of transitions in care throughout the community. So it can be from correctional facilities, you know, to a crisis facility, or to home, or even out in the community due to homelessness. Really depends on the situation. And then we have a lot of folks leaving the hospital that, whether or not they have housing, they have a variety of treatment needs that may require a placement other than their home setting. And some of the ways that we address this are, for the discharge packets, what we've done is, well, for the entire discharge process, we have some dedicated teams in place. We've got the term most are familiar with our hospital liaisons. Our dedicated discharge planner team fills that role. They're assigned to specific facilities. So they build relationships with those hospitals and the staff who work in them to help get information as we go and coordinate care between inpatient, outpatient, and any facility that the member may need to go to. We also have a 24/7 line, as well as an email address for those folks. It's our administrator on call, which we term in-house as our linkage liaisons, because they really do, their linkages between judges, crisis mobile team, hospitals, pharmacies. You know, they often work with Genoa to help get injections and other medications delivered to facilities and crisis centers who may not have something in stock. We have a specific fax and discharge packet email inbox that we've provided to all the hospitals, which, you know, more and more we're getting that information just sent to us automatically, sometimes even the same day as discharge, which is good because, you know, as most folks know, the requirement and the thing that best serves our member is to have them seen for at least their hospital discharge appointment with the behavioral health medical professional and team within 1 to 7 days after discharge. We've got lots of options for CODAC, as well as with our system partners out in the community, for any type of treatment service that a person may need when they're stepping down from a hospital setting. And again, Genoa helps with that because they'll help deliver medications, put medications into spill packs that match whatever the prescriber has indicated for the length of time the member should have meds for. We use, for a lot of our placements, we use a Crisis Bed Connect link. There have been so many more residential and transitional placements that have established care in the last year or two, and you can find out who's got a bed open and who doesn't, and how to contact them using that link.
Thank you.
Mhm.
All right, so our second question for today. What are the biggest negative impacts that CODAC sees for patients going through transitions of care? How has your discharge program addressed some of those pain points?
Yeah, so the social determinants of health are probably one of the biggest factors there, because we have folks that, they're experiencing homelessness, they have lack of income, transportation, resources, and social supports in general. So we had a lot of folks previous to a year from now struggling with making it to that discharge appointment, the follow-up after hospitalization. So what we did, it was actually September 7th, a year ago, we implemented a program where we have a dedicated behavioral health medical professional, medical assistant, and peer support staff who work to be extremely flexible and work members in, lots of people coming out of crisis situations. They may not make an appointment on time, or maybe even not on the right day. And we just want to make sure that we do whatever we can to help them connect to that appointment, so they get their needs met, especially their medications, which oftentimes will prevent them from returning to an inpatient setting.
Mm-hmm.
Our peer supports that work within that discharge program, they also are issued mobile equipment so that they can go out into the community and assist members who may not be able to be transported into a treatment site for one reason or another. They also, using their mobile equipment, can help complete a telehealth appointment if a member doesn't have the equipment to do that on their own. And then once that's all complete, they also can assist them with communicating with the pharmacy and helping to obtain their medication refills and setting a schedule for them to continue to be able to get them filled. Most of our members, when they come out of a hospital setting, aren't even aware that their medications can be delivered. So that is something that has been extremely helpful. Just giving that information to them has helped a lot with reducing recidivism and helping people remain stable.
I know Katie and I, in our experience, working with CODAC, really seeing that integration and help to make sure our consumers are getting their medications during that time. And if there's any barriers, that we're working together to make sure that they're getting it and delivered before the end of the day. I know sometimes with those residential homes, it's very important, they won't be admitted if they don't have some of those medications as well. And if it's not accurate, what was discharged.
Yeah, that's absolutely true. And I know I oversee our transitional programming as well for one of our locations, and having a dedicated staff at Genoa that has assisted with setting up deliveries, making sure dispel packs are done on time, and even communicating with us when a member is not picking up their medications on time, or they, for whatever reason, a refill wasn't sent. It's timely so that we can address the issue quickly and get it solved. So having that single point of contact or that dedicated staff at Genoa has really helped in that respect.
Thank you. Looks like we can move on to our second poll question by Katie.
Yes, thanks, Joey. In your experience as a care provider, which of the following has the biggest impact on your patients who are going through transitions of care? Is it cost of care? Is it poor communication between care teams? Is it mismanaged medication or treatment plans? Or is there something else? If it's something else, please add that to our chat. And from like the statistic we had at the beginning of the presentation, communication is the biggest challenge that we see. So 75% of you said poor communication between care teams. And I'd also like to add that this also includes data from a LinkedIn poll that we posted about 2 weeks ago leading up to this presentation. So this includes from the general community as well, what they experience. After that, we have some other. And than the others, cost of care and poor management of meds. And back to Joey and Nancy.
All right, Nancy, how has your discharge program improved health outcomes for those transitioning from inpatient to the outpatient settings?
Well, again, I believe the follow-up after hospitalization clinic and process that we implemented has probably had the biggest impact to make sure that our members get all their needs met within that 1 to 7 days post-discharge. And it has made it so that in the year that we implemented that clinic, we were really struggling to get our members served in that time frame and make sure that they were able to connect for whatever reason that they were having challenges with. And it's improved us to the point that we are meeting and in some cases exceeding our HEDIS benchmark measures.
That's awesome.
Which means that translates into much better care for the member and more stability and less recidivism.
All right, we'll move on to our fourth question. What does the journey for a court-ordered treatment patient look like from beginning to end? And then how does CODAC ensure successful completion of their treatment plan?
Okay, yeah. So a member can come to us in a couple different ways for court-ordered treatment. It could be an already enrolled and established member at CODAC who just needs extra care, attention, and supervision in order to stay connected, to stay engaged in their treatment. Or it could be a member who has admitted to a hospital and they're not enrolled with any agency. So in that second scenario, there's something in place called an urgent engagement process where CODAC will get an email that initiates an urgent enrollment. And within 24 hours, we get their chart set up, we get the hospital staff, the dedicated discharge planners and linkage liaisons to help connect the member to our services, get a treatment plan in place and get that turned into the courts. Then we move from there to see what type of fund source they have. There's a crisis funding for a short time for 45 days for folks who don't have any fund source at all. And then also an SMI evaluation to assist with folks who might not be able to get access or Title 19 funding. They still would be able to get the psychiatric assistance, including medications, if they're placed on court-ordered treatment. And then we, of course, have that dedicated technician at Genoa that helps keep us informed of any medications that haven't been picked up timely, insurance issues, whatever there is. And it helps a lot with getting those things resolved a lot more quickly than if we didn't know about them, so far in advance. And then that can also mean that that dedicated technician will help us communicate and coordinate between insurance plans to get the members' meds billed.
Awesome. I would like to add that I know for these, intensively med-managed consumers, the court-ordered treatment, one of the benefits of just partnering together is utilizing that adherence packaging that we have, which we call the DISPIL packaging. And I know, those that are managing their medications, it's easier for them to tell whether they're taking it or not, and it helps remind them of those medications, making sure they're taking them adherently.
It absolutely does. And having it to set to whatever time frame the prescriber has indicated, whether it be a week of fill, 2 weeks, a month at a time, that's also extremely helpful.
Absolutely. All right, we can move on to our next one. Alrighty, so this will be our last discussion question. I know many inpatient settings in Southern Arizona have talked about the barrier of making sure consumers get their LAIs timely after discharge. So at CODAC, if a patient is receiving an LAI in the inpatient setting, how do you all ensure that their treatment is consistent and timely after discharge?
Well, that's where kind of everything comes together that we've talked about here today, where we've got the dedicated discharge teams and planners to help communicate between inpatient and outpatient. they've got those relationships built so that if we're missing a discharge packet or the LAI info from the discharge summary, then we can oftentimes a lot more quickly get that information from the inpatient folks. And then we've got we have a system for alerts in our chart set up to let people know that this is when the next LAI is due. And then when they come in for the outpatient appointment, the follow-up after hospitalization, that also alerts folks that this needs to be scheduled so that they may need one here when they come out, or they may have already gotten it and the next one is due on this date, just to keep us in compliance. And then using an in-house pharmacy is extremely helpful as well.
Great. Yeah, all the things you've discussed today, really kind of putting it together to improve those health outcomes during transitions of care. And obviously you've seen it in your, HEDIS measures, and really impressive program that you all have.
Thank you, George.
We can move on to our third poll question that Katie will be presenting.
Yes. Once a patient is discharged, who at your clinic coordinates the next steps in care? Is it nursing staff? Is it the front desk? Do you have medical assistants, dedicated discharge coordinator? Is there no designated staff, or is there somebody else other, which I'm hearing that maybe the chat isn't working. So feel free to add it to the Q&A section because I can still see those. So 54% of you said there's a dedicated discharge coordinator. After that, no designated staff for this responsibility. Front desk is helping, and then some other staff that may be responsible for helping coordinate patients coming out of the hospital. And our fourth poll, if you don't have a dedicated discharge coordinator, are the extra responsibilities of patient follow-up causing a burden on your staff? Yes or no? And from Emily Carroll, she said that we have a discharge team, not just one person. This includes front desk, among other staff. Interesting, 50-50, yes and no, causing a burden on your staff. I would not have guessed. And now, has Bill joined us?
Yes.
Hey, Bill, how's it going? We've got Bill Wrigley, Director of Product Immunizations. He is going to give us an update on COVID-19 and flu. Welcome, Bill.
Hey, everyone. How's it going today? Sorry, just getting set up here. Can everyone hear me okay?
Yep.
Awesome. Well, thank you for allowing me a brief opportunity to just provide a few updates related to COVID-19 vaccine, as well as the flu vaccine season that's rolling out here hot and heavy in September. So with that, Megan, can you advance the slide? Thank you. All right. So the new news in COVID-19 vaccine world are these new bivalent boosters. Those were rolled out here at the beginning of this month, early September. So what makes these unique is they target the circulating Omicron BA4, BA5 variant. They have mRNA components that cause expression of the spike protein that is unique to the BA4, BA5 variant. So in addition to the kind of traditional or original formulation of the vaccine, these are targeting that circulating variant as well. You can think of it similar to, flu vaccine. If you've kind of heard the term quadrivalent vaccine, that's targeting the best guess at the CDC and WHO as far as the 4 circulating strains they think will be in a given flu season. This is kind of a similar concept where, again, in addition to the original version of the COVID virus, it's targeting this variant. So both Pfizer and Moderna now have an authorized bivalent booster, and as far as being available, Pfizer was kind of ahead of the game in their distribution and or manufacturing and distribution. So that has been widely accessible. Moderna has been a little tougher to get in the early goings of the rollout, but I think in probably the next week or two, the supplies will kind of catch up, and shouldn't really be any challenges for our sites or any vaccine providers out there in obtaining the Moderna bivalent. One thing to note is that with the kind of FDA and CDC implementation of the monovalent vaccine, or excuse me, of the bivalent COVID vaccine, monovalent is no longer authorized as a booster. So, all previous versions, those original versions of COVID vaccine in any age group, excuse me, I should say that monovalent is still authorized as a booster in the 5 to 11-year-old population, but anyone 12 and older, the monovalent is no longer authorized. They are still the products that are authorized for initial doses, so dose 1 and 2 for someone who's never had a COVID vaccine before, but they have kind of retired them as boosters. And with the new bivalent boosters, the data and things that have come in thus far seem to indicate expecting, similar side effects that have kind of been seen throughout the COVID vaccine rollout. So injection site pain being the most common, then things like fatigue and aches have kind of been noted in similar prevalence as to the original versions of the vaccine. Right. So who's eligible for a bivalent booster? And I hope this is, to me, it seems a much more simplified than some of the previous recommendations that have come out from ACIP and things that are, where we've had to do a little bit more, decision tree on who should get a shot or not. So essentially anyone who's 12 and older, and it's been 2 months since their last shot, no matter if that shot was a booster or an initial vaccine, completion, are eligible for this new formula, or for this new formulation, the bivalent version. So at this point, Pfizer is indicated for individuals 12 and older, and Moderna is indicated for individuals 18 and older. So if at previous, there's been something about how many boosters that they had or things of that nature. That doesn't apply here. If someone never had a booster, if they had 2 boosters of the old version, it's really just that time since last dose. FDA, CDC want everyone who has been fully vaccinated with an initial series to get this new bivalent version. So it's hopefully a little bit more simpler there to figure out who should get these. And you don't have to take the slide back, but one thing I did want to point out was in that 5 to 11-year population, like I had mentioned before, currently there is not a bivalent booster approved in that age group, but I would expect to see one probably within the next month for the 5 to 11 population from both Pfizer and Moderna having approved products for that younger age group. All right, and then just a few notes on flu vaccine this year. One thing that was kind of, we were monitoring us in the kind of focus in the vaccine world was typically we look at Australia and the flu season that they kind of see occur as a leading indicator as to what folks in the Northern Hemisphere might expect. And so because they have kind of an opposite, winter as we do, their flu season runs kind of opposite of ours. So just kind of finishing up. And what they saw was the most severe season in 5 years. And also cases were kind of ramping up earlier than they had seen in the last few years. So not necessarily a guarantee, but a potential leading indicator that we could see a more severe flu season than we've seen over the last couple of years here in the United States, which is, kind of logical as we think of, the with COVID and all of the things that were being used to mitigate COVID probably tamped down flu activity with masks and social distancing and things being closed down, et cetera. Most of that is obviously in the past. And so, could see some spikes in flu activity this year. Just a reminder that I get this question a lot. They can be co-administered with a COVID vaccine. So if you're getting a flu shot and are needing a bivalent COVID booster, those can be administered at the same visit. And then one last kind of change in the flu vaccine landscape this year that I wanted to point out. So there has been a couple of products, either high dose, which is I believe Flu Block, and there's one other brand name, or there's an adjuvanted quadrivalent flu vaccine called Fluad that have been indicated for the 65 plus population. Up until this year, ACIP has not necessarily given a preferential recommendation to those products. Even they just kind of said, well, it looks like the data shows that those are beneficial in that population. They're FDA approved in that population, but they didn't come out and fully recommend that individuals 65 plus get that. This year, they kind of, I guess, reinforced that, yes, individuals 65 plus are recommended to get either a high dose or adjuvanted presentation of flu vaccine. And so with that, I know as an organization, we really tried to increase our allocations of that 65 plus product, just making sure that we could meet demand. But there is, I just wanted to point out as well, if someone is kind of presenting at a flu clinic or for a shot and they're 65 plus and that presentation is not available, CDC does recommend that just the age appropriate or kind of standard quadrivalent vaccine be administered. Obviously, if the patient chooses, no, I'm going to, I do not want to get that. I want to go get a version that is indicated for my age, and as far as preferentially indicated, the high dose or adjuvanted, that's fine. But they say if the patient's there and kind of willing to give you their arm, go ahead and give them a shot, because if they leave that day, there's a risk that they won't go back at a later date and get any vaccine. And the standard quadrivalent in that age population is better than no vaccine. So with that, I am done with my content. Did any vaccine specific questions flow in, Megan, while I was going through the content briefly?
They sure did, Bill, but so far only one.
Okay.
But a great reminder, if any of you have questions, please put them into the Q&A, whether for Bill or Nancy or Joey or I. But first question for you, Bill. I've read that each dose of Pfizer's contains 30 micrograms of vaccine. Moderna went with a much larger dose of vaccine, 100 micrograms. What does this mean?
Yeah, so that is the approved micrograms of, I guess I'm not sure how they actually measured, active ingredient or what have you. I can go ahead and take that one back. I'm not sure if that's just related to, how things were studied in the original trials and what, what kind of ultimately they landed on was the best dose for their product. So I don't want to kind of posit an answer that I'm not very clear on, so I can take that back. But as far as efficacy, both products have been, fairly robust at preventing severe disease, and both have had, as the pandemic has gone on, their challenges, and as far as I've seen, been fairly similar at, preventing transmission. That hasn't really been, especially as variants have come out and things, there's been kind of less of efficacy at preventing, transmission from one person to another, but that, overall protection from hospitalization and death has been fairly strong throughout for both products.
Great. Thank you. And a comment from Richard Brewington, he said, Moderna is more likely to cause myocarditis in young men. So interesting to know that. And then I've got a couple of questions directed towards CODAC. So Nancy, if you feel comfortable answering these, or if there's anything we can follow up on. The first question, are your transition programs based upon an evidence-based practice or emerging best practice model? And if yes, which model do you follow?
I could certainly collect information and, send that back to you all to distribute.
Yeah, absolutely. The next one is, I struggle with getting my patients to follow through with the discharge program. For example, many patients won't answer our phone calls or respond to communication efforts. How has CODAC addressed that issue?
I think we're kind of, all in the same boat there. We share similar struggles. One of the things that we have used, a tool, has been the HIE. We oftentimes will find that when our members go to hospitals, they will provide contact information that we don't necessarily have in their chart with us. And we've been able to contact many people that way. And then another way is that if we're not getting an answer or not able to find good contact information for the phone, our team of peer supports will go into the community to look for them at an address, last known address, or information that we get from HIE.
Awesome. Thank you, Nancy. What are some of the positive outcomes that you see in patients with your post-discharge program?
Yeah, sure. So like I talked about a little bit, we see more stability, which means less recidivism. So less of a cost to the system is how that translates out. But so it helps people connect to the appointment, get their medications, remain stable, and not need the crisis services right afterwards again.
That's great. How do you address other care factors in the post-discharge conversation, for example, seasonal vaccinations?
A lot of that occurs between the peer support, the medical assistant, and the behavioral health medical professional, both before, during, and after those appointments.
Awesome. Okay, I have one more for you, and I have one more for Bill. So for you, Nancy, how do you address care coordination when discharging a patient with comorbidities? For example, many of our patients have type 2 diabetes or other healthcare considerations.
Yep. So we work to ensure that the discharge information, the discharge packets, and all the medication discharge summaries, we have them together. And there's a process in place. Everyone has their own criteria for what they want in referral packets. But if somebody's going someplace other than home and they're going to a residential or a transitional facility, we do our best to make sure that those medications are all served through one pharmacy and filled that way, so that it's easier for the patient to keep track of. And because residential is a temporary setting, if they are going to go on to back to independent housing or wherever they're going from there, that also helps them to be able to manage their meds afterward. So just try to do as much as we can to help that patient connect to all the services they need in terms of primary care and behavioral health for appointments, medication, fills, and what they're going to do for a plan after all that is done.
Yeah, keeping all those records in one place is helpful because there's a lot of information going around. So thank you. Thank you, Nancy. And then Bill, I have another question for you. If someone is traveling and needs multiple vaccinations, can they receive all of them, for example, 6, if they are not live vaccines?
Yep. Am I off mute? There we go. Sorry. Good question. I was actually looking at this a little bit. I don't know if it was late last week or earlier this week. The short answer is most of the time, you kind of want to look at exactly which vaccines they're giving and if there's any specific patient characteristics that might lead to a contraindication. But in general, most of the the non-live or the attenuated type vaccines can be co-administered at the same visit. Just wanting to probably use either some as much space as possible between injection sites in the same arm, or using both arms to kind of for comfort purposes. But as far as vaccine efficacy, the CDC has some decent guidance in their yellow book that I can kind of provide a link to after the call here as we collect the questions and answers, and for more kind of specific information related to each individual vaccine.
Great, thank you, Bill. And then I just have one more comment. This is from Susie Howe. She said, we recently discovered that hospital pharmacists will take our Genoa bubble packet and update it to match discharge instructions from the hospital. Since they are located 45 minutes from the Genoa pharmacy, it's been very helpful. So thank you for sharing that, Susie. And a special thank you to Nancy. Thank you so much for joining us today and sharing about some of those special things that you guys are doing at CODAC to take care of patients. We are so grateful that you joined us today.
Thank you for having me.
Yes. And that will conclude our Transitions of Care talk today. So thank you so much for joining us. We loved having you. And we will follow up with Peter Genoa with the question for Nancy. Thank you so much.